So today we are going to talk about scapula. So we know this is the bone scapula, which is also known as shoulder blade, which is like very important bone because when we are dealing with any patient who is having shoulder pathology, they have issues with the position of the scapula because of the muscle weakness or tightness. So therefore we need to know about the part of the scapula. As a physiotherapist, it's very important to have a good shoulder stability. When I want to work on a patient who is having poor shoulder stability, I need to know that which all important structures are present over here in this bone. तो एज ए फिजियोथेरापिस्ट मुझे ये जानना ज़रूरी होता है और मेरे कई सारे पेशेंट में दे हैव दिस इश्यू दैट they have either shoulder instability, scapular instability, or scapular dyskinesia. So the problem is related with the attachment on the scapula. So the first thing what we see will be the where this bone is present. So this is a very thin bone. We can see that it's a thin bone, okay, and this is placed on the posterolateral aspect of the thoracic cage. So this is my thoracic cage, and this is placed over here. So in this way, this bone is present on this area. The bone is present. So this is your scapula bone. It has two surface, the costal surface and dorsal surface. It has three borders, the lateral border, middle border, and superior border. It has three angles, the glenoid angle, medial angle, and the inferior angle, and it has three processes, the spine of the scapula, then acromion process, and coracoid process. In this, all the structures are present over here. We'll see each of them in detail. So the first we'll talk about the side determination, how I'll know that which side of scapula bone this one is. So if I want to hold it anatomically, if I want to present it, अगर मुझे इसको present करना होगा तो I'll keep it, hold it in this way. So how it should be? सबसे पहले it has a lateral or glenoid angle which is having a large and it bears a glenoid cavity. So इसका जो lateral angle होता है जिसको glenoid angle भी कहा जाता है, जो ये portion है जो सबसे बड़ा होता है among this other angle, this is the larger one, and it has a cavity over here which is called a glenoid cavity. Now this glenoid cavity is taking part in making your shoulder joint, so it is connected with the head of the humerus. In that way, it is making your shoulder joint. So the first thing is for the side determination, this will be the lateral angle. It means it will be out towards or away from the midline. मतलब ये lateral angle है, glenoid angle जो है वो lateral side होता है, तो वो mid line से हमारी mid line से दूर की तरफ होगा. So might be it is in this way or it is in this way. Okay, तो पहले मैं ये बात कर लेता हूँ. Then it has a dorsal surface which is convex in nature. So here this one is the dorsal surface. This spine, you will get a spine over here, spine of the scapula. It is a dorsal surface, and this spine of the scapula is dividing your dorsal surface into supraspinous fossa and infraspinous fossa. So very important muscles are attached over here: supraspinatus muscle and infraspinatus muscle. Then the costal surface, this is your costal surface. You can see over here, this one is the costal surface. Costal surface is concave with subscapular fossa. It is a concave in nature and it has a subscapular fossa. And there is a lateral border, the thickest lateral border. Among all other borders, the lateral border is the thicker one. So in that way, accordingly, this is my right side of the scapula. Okay, this is the right side of the scapula. So अगर लेफ्ट साइड होता तो ये वाला पोर्शन बाहर की तरफ होता. Okay, the lateral border will be this side, but this is right side, so it is in this way. I'm going to fold it in this way. This is convex concave surface जो है, जो costal surface होता है जो आगे की तरफ होगा, एंड जो स्पाइन ऑफ द स्कैपुला वाला जो सरफेस होगा जो सुप्रास्पाइनस इंफ्रास्पाइनस में डिवाइड होता है वो पीछे की तरफ होता है, which is called as dorsal surface of the scapula. The features of the scapula. So we can see it has a costal surface and dorsal surface. The costal surface has a subscapular fossa, which is giving attachment to the subscapularis muscle, and it has a three longitudinal ridge, which is giving an impression for the ribs. So because it is lying on the thoracic cavity, costal surface, it is on the ribs, it is on the ribs, or it is on the this longitudinal margin, it ridges to have. वो दिखाता है कि द अटैचमेंट विद द रिब्स की वजह से ये होगा. Now, this part of the bone is almost rod-like. Okay, so this has another thick ridge adjoining the lateral border. Okay, and this part of the bone is almost rod-like. It acts as a lever for the action of serratus anterior overhead abduction of the arm. So what is happening? The three longitudinal ridge जो होता है and another ridge which is there on the lateral border, ये सारी important ridge होता है and which act as a uh, uh, लीवर. तो आपका जो सेरेटस एंटीरियर होता है वो अटैच होता है ओवर हियर ऑन द मिडिल सरफेस. ओके, वो यहाँ पे अटैच होता है. अभी ये सेरेटस एंटीरियर जो मसल है, जो एक इम्पॉर्टेंट मसल होता है, जो आपके ओवरहेड एक्टिविटीज के लिए बहुत काम आता है, प्लस इट इज हेल्पिंग यू फॉर द स्केपुलर स्टेबिलाईजेशन, फॉर स्केपुलर स्टेबिलिटी. फिक्स योर स्केपुला टू विथ योर थॉरेसिक कैविटी. थॉरेसिक कैविटी के साथ इसको फिक्स करके रखते हैं, इसको ऐसे होल्ड करके रखता है. अगर ये नहीं होता, वीक होता, तो ये ऊपर उठ जा देता है ऐसे. सो इट फिक्सेस योर स्केपुला. The another one is the dorsal surface. So on the dorsal surface, if you see in this way, it has a spine of the scapula. This is the crest of the spine. Okay, ये पूरा का पूरा spine of the scapula होता है. ये spine of the scapula आगे convert होता है acromion process के अंदर. It has the two fossa, supraspinous fossa and infraspinous fossa. The larger one is the intraspinous fossa, which is the lower one, and above the spine is the supraspinous fossa. So and these two fossa are connected by the spinoglenoid notch. So we have a spinoglenoid notch over here, जो आपके दोनों fossa को connect करता है. So in that way, the important this is the surface, the features. Okay. Now in the features, in the upper cell surface, we are going to talk about the borders. In borders, we can see in the diagram. So it has a lateral border, it has medial border. Okay, these are the two main larger border: lateral border, medial border, and superior border is over here. So superior border is a thin and very shorter one, and near the end of it, it has a connection with the, or it is making a coracoid process. So coracoid process, and it presents a suprascapular notch. So यहाँ पे होगा suprascapular notch. Then it has a medial border and lateral border. So lateral border is the thicker one. It has an, in the upper end of the lateral border, you will get an infraglenoid tubercle. यहाँ पे आपको infraglenoid tubercle मिलता है, जहाँ से long head of triceps origin होता है. The tricep muscle जो आपका back of the arm muscle होता है, कई बार जिम में हम लोग उसकी special exercise करते हैं. So that is attached over here. Then you have medial border, which is very thin and extends from the superior angle to the inferior angle. So ये जो आपका पूरा होता है वो medial border होता है. यहाँ पे superior angle है, यहाँ पे inferior angle है. तो इस तरह से वो exist करता है. So you have three border. आपके पास तीन border है scapula के अंदर. Superior border जो ऊपर का border है, medial border जो midline की तरफ होता है, lateral border जो away from the midline होता है. So in that way, these three borders are present. Then you have angles. So the angles में की अगर हम बात करें, so in the angles you get the superior angle, you get inferior angle, and you get glenoid angle या फिर lateral angle. So the superior angle is covered by the trapezius. Trapezius is a larger muscle on the upper back. तो ये आपके superior angle को cover कर देता है. It doesn't have any connection with that, but it is covering that. It is covering the superior angle. You cannot feel it. Then you have inferior angle. यहाँ पे आपका latissimus dorsi muscle का attachment होता है. On the inferior angle यहाँ पे latissimus dorsi is attached, and you have a lateral angle or glenoid angle. So this is, we are like having a big fossa over here, which is called as glenoid fossa, and this is directed laterally upward, laterally forward and upward. ये थोड़ा सा laterally forward और upward present होता है, जिसकी वजह से आपका head थोड़ा सा head of the humerus होता है वो आगे की तरफ रहता है. And people who are having tight pectoral muscle, वो केस में वो पूरा ऐसे आगे की तरफ आ जाएगा. So it should be in this way. Okay. अब सो तीन एंगल हुए आपके. एक है सुपीरियर एंगल जो ट्रेपेजिस के अंदर कवर है, एक है इंफीरियर एंगल जो लैटिसिमस डॉर्साई के को अटैचमेंट देता है, एंड एक है ग्लिनॉइड एंगल व्हिच इज हैविंग अ ग्लिनॉइड कैविटी. तो ये ग्लिनॉइड कैविटी एज आई शोन यू अर्लियर आपके हेड ऑफ द ह्यूमरस के साथ अटैच्ड होती है. Then you have processes. In processes, you have the spine of the scapula, spine process. Then you have acromion process, and you have coracoid process. So this coracoid process is the shorter one, which is giving attachment to important muscles like shoulder biceps. Then coracobrachialis को origin करेगा और साथ में pectoralis minor को insert करेगा. Then this is acromion process. Acromion process is having two border, lateral and medial. ऐसे देखा जाए तो ये lateral और medial है, two surface and superior and inferior surface होता है. यहाँ पे आगे it has a facet जो clavicle के साथ attach होता है and it is making acromioclavicular joint. So, so it is making a joint called as acromioclavicular joint. I will show you. So this is the clavicle which is connected over here, okay, in this way, and it is making the acromioclavicular joint. It is in this way, it is making a joint. This is of other side of the clavicle, and this is right side and clavicle was of left side. That's why that. Okay. Then it has, this is the spine of scapula, the crest of the spine, and this gives attachment to your important muscle trapezius in upper lip and deltoid in the lower lip. So in that way, these are the important processes which we see on the scapula. Now the main part is the muscle attachment. As a physiotherapist, we need to be thorough with this because many patients who comes with the shoulder pain, they may have either tightness or weakness of particular muscles which are connected with the scapula. So that's why we need to have a good proximal stability. ये अच्छे से stable होगा तो आप अपने upper limb की activities को काफी अच्छे से कर पाओगे and you can prevent many kind of scapular or joint, shoulder joint problems. So the first muscle which we are going to talk about is subscapularis muscle, which is connected over here on the subscapular fossa. The larger portion of the subscapular fossa is giving attachment to the or origin to the subscapularis muscle. Is mainly the medial two-third of the subscapular fossa के अंदर आपका यहाँ पे subscapularis muscle होता है. Then the next is supraspinous fossa, supraspinatus muscle, which is originated from the supraspinous fossa. Okay, even with the upper surface. Then infraspinous fossa में से आपका infraspinatus muscle origin होता है. Then you have deltoid, which is getting originated from the lower border of the crest of the spine and lateral border of the acromion. So from here, origin उसका जो होता है posterior fibers का वो lower border of the crest of the spine, and the middle fibers are originated from the lateral border of the acromion process. Trapezius, which is connected over here, inserted on the upper lip of the upper crest of the spine of the scapula, and also the middle border of the acromion. So यहाँ से लेके यहाँ तक आपका trapezius का insertion होगा. We can see in the diagram also, and you can also see it in the textbook. Mainly, this is I have taken it from the BD Chaurasya, which is very easy to understand. The next is serratus anterior, a very important muscle for your scapular stability. And if the patient is having weakness of this muscle, the scapula will not be able to get fixed on the thoracic cavity. So serratus anterior muscle is getting inserted in the form of 8 digitation. और ये आपके mainly serratus anterior जो होता है, we can see it is inserted on the medial border. Okay, so it is inserted in the form of 8 digitation. The one digitation that inserted on the superior angle to the root of the spine, 2 will be at the medial border, and 5 digitation will be at the inferior angle. So it is originated from the 8 digitation from the upper 8 ribs. From here it is getting originated. It goes back. पीछे जाके it is coming below the scapula and then inserted over the lateral, medial border of the scapula. So the first digitation is inserted in this much area, superior angle to the root of the spine. Second digitation on the second two digitations, the second and third digitation are inserted over here from the root of the spine of the scapula to the medial border up to the inferior angle. And on the inferior angle, the another remaining 5 digitations are inserted. Then your long and short head of the biceps both are getting originated from the scapula. The long head is getting originated from the supraglenoid tubercle, which is above the glenoid cavity. Glenoid cavity के ऊपर होता है. यह है glenoid cavity. यहाँ पे इसके ऊपर you will be having attachment to the long head of biceps. Short head of biceps getting originated from the coracoid process, tip of the coracoid process. Then we have coracobrachialis. It is also along with the short head of biceps. It is getting originated from the tip of the coracoid process. Then we have pectoralis minor insertion, which is inserted again on the tip of the coracoid process. Inserted. The pectoralis minor is inserted over here, but short head of biceps and short head of the short head of the biceps and coracobrachialis, both of them are originated from the tip of the coracoid process. The long head of the triceps is getting originated from the infraglenoid tubercle, below the glenoid cavity, infraglenoid tubercle. So in that way, the attachments are present. Then you have teres minor, teres major. They are originated from the lateral border of the lateral border of the scapula. So if you see the teres minor, it is originated from the upper two-third of the rough strip, upper two-third is for the teres minor, and lower one-third is for teres major. On the lateral border, upper two-third is for the teres minor, lower one-third is for the teres major. The levator scapula is inserted along the dorsal aspect on the medial border. On the medial border, dorsal aspect from the superior angle to the root of the spine. Then rhomboid minor is inserted on the medial border, opposite the root of the spine, and यहाँ पे over here between the root of the spine and inferior angle you have rhomboids major. So levator scapula इतने एरिया में इंसर्ट होता है. खत्म मतलब इंसर्ट होना मतलब कि खत्म होना. यहाँ पे आता है आपका rhomboids minor and then rhomboids major. तो ये आपके dorsal surface but over the medial border. ओके okay? अभी मैंने ऐसे पकड़ा था, इसको मैंने ऐसे घुमा दिया है, तो ये एरिया पे आपका levator scapulae, then your rhomboids minor and rhomboids major are inserted. Then even the inferior belly of the omohyoid muscle, which is arising from the upper border near the suprascapular notch. So you have suprascapular notch over here. उसके बाजू में से आपका the belly of the inferior belly of the omohyoid muscle जो होता है वहां से origin होता है. Then the next is the important ligamentous attachment. So glenoidal labrum is attached to the rim of the glenoid fossa and it makes it more deeper because of the glenoidal labrum. आपका glenoid cavity अच्छे से deep होता है, otherwise ये बहुत ही shallow है, जिस वजह से वो dislocate के chances बढ़ जाते हैं. But because of glenoidal labrum, it doesn't get dislocated. Then you have then you have acromioclavicular ligament, the capsule of acromioclavicular joint, which is connected over here. Then coracohumeral ligament, which is connected from the coracoid process to the humerus, which we can see in the diagram also, the purple color, light purple color. Then coracoclavicular ligament, which is connected with the coracoid process to the clavicle जो यहाँ पे insert होता है, उसके साथ यहाँ पे attach होता है, acromion process के साथ वहाँ तक होगा. Then transverse ligament transverse ligament and your spinoglenoid ligament. So all these ligaments are present over this. So the transverse ligament bridges across the suprascapular notch and converts it into the foramen. So over here you get a transverse ligament. Okay, this is in this way you get transverse ligament, and spinoglenoid ligament, it bridges the spinoglenoid notch. So you have spinoglenoid notch over here. तो वहाँ पे आपका spinoglenoid ligament होता है. So these are the important attachments seen on the scapula. Now the clinical anatomy. So patient who is having, as I told you, serratus anterior, very important muscle for the scapular stability. So if the patient is having serratus anterior weakness, it can give rise to winging of scapula. The medial border will be prominent. If you ask the patient to push the wall, on that time the medial border of the scapula will become prominent. So we can see in the first diagram, in this one, this is your winging of scapula. Then scaphoid scapula is a condition when the medial border, which is normally is convex, उसके बदले it will be concave in nature. So the middle border will be concave, which is an anomaly, which happens since birth. तो ये anomaly होता है, एक abnormal structure होगा. Spongial deformity is another kind of scapular deformity जहाँ पे scapula की position ठीक से नहीं होती है. Abnormal it will be higher, so that is the spongial deformity. And this another one we can see that fractured scapula. So this is again happens in case of direct trauma over the scapular area. If the person is falling on outstretched hand, that they can have this kind of scapular fracture. So these were the few of the clinical anatomy. The others are like scapular dyskinesia. You can see scapular dyskinesia in that the first one is overactivation of the upper trapezius, which causes upward position or during the movement scapula moves upward. जो normally होता है, but इसके अपने normal timing के पहले अगर वो ऊपर चला जाएगा, that is called as elevation disconnect pattern. Then there is anterior tipping, which is mainly because of occurring because of inferior trapezius, lower fiber of trapezius weakness, and at the same time, pectoralis minor tightness also can cause this issue. So in that way, different types of scapular disconnect pattern can be seen with the shoulder pain, which as a physiotherapist we need to focus it more. So this were about the clinical anatomy. So here we come at the end of this topic, scapula. I hope you had been got your doubts clear. अगर आपको कोई भी doubt हो, आप you can inform me. You can write down the message. Okay. Thank you.